Dear friends, at the outset, I like to thank IOS, Professor Russell Reid and Professor Annabelle Okada for giving me the opportunity to speak on the topic of primary hypertensive uveitis. It's a quite a vast topic and can be a bit dry, but let me try and sum up in next 7 to 8 minutes. So before we go into primary hypertensive uveitis as such, what are the possible mechanisms of high IOP in uveitis? As we all know, hypertensive uveitis by itself is a standalone entity, but it can be acute, recurrent, or chronic, and depending on patient to patient, it can present to us in various form. What happens here? It is there is a aqueous barrier, blood aqueous barrier, which is disrupted, resulting into the anterior inflammatory cells into the anterior chamber, and also increase outflow resistance, causing the imbalance between the aqueous production and the aqueous outflow. And this is what can happen in patients with the high IOP in uveitis. So it can present with open angle, or it can present with closed angle, or it can be also a specific entity called as steroid induced. Now, when we speak about the primary hypertensive uveitis as such, we are particularly talking about the patients whom particularly initially presents with the hypertension and the inflammation, the high IOP and the inflammation at the very beginning of the disease itself. And in this context, a big chunk of the diagnosis goes to the viral uveitis. So I'll be focusing mostly on the viral uveitis, including the Postner-Schlossman syndrome and the Fuchs uveitis, which is also known to be associated with the virus. And just to quickly touch upon the steroid response, it can be a difficult topic and it can be a difficult thing to manage, and we really do not know too much into it, but we do know that it can occur at any time after starting the corticosteroids, and then there is no particular consensus about management of this thing. Now, going into the depth of viral anterior uveitis, it should be suspected in the patients with the high IOP or the iris atrophy and associated with inflammation. It can present with or without KPs or creative precipitate, with or without corneal scar. It can be a syndrome called as Postner-Schlossman syndrome, which we are all aware, or it can be a syndrome of Fuchs heterochromic iridocyclitis or Fuchs uveitis syndrome. The commonly associated virus implicated in the patients with hypertensive uveitis are HSV, VZV, CMV. And there is a significant number of CMV anterior uveitis which we see in this part of the world. Now, what are the different phenotypes, and how does the viral anterior uveitis present with? It can present, as I mentioned in my previous slide, it can present with the granulomatous inflammation with medium to large or even the smaller keratic precipitate. It can also present with corneal scars, and it can also present with corneal edema. Particularly in patients with the Fuchs uveitis syndrome, it is a chronic low-grade inflammatory disorder, more restricted to the anterior part of the eye, but also can present with vitritis or the vitreous inflammation. The key clinical features in context of Fuchs heterochromic iridocyclitis are stellate keratic precipita, which are diffusely distributed, non-confluent. Iris heterochromia might be seen, but not necessarily mandatory in all the patients. Iris atrophy, Kepi's nodules, Amsler sign has been reported. Vitritis can be seen, and it is pathognomonic of when there is no posterior sign AK. So that's the pathognomonic sign. When you speak about the Postner-Schlossman syndrome, there is only where there is no confirmed diagnosis of any specific etiological agent, and then you call it as a Postner-Schlossman syndrome. Now, I want to spend a little bit of time speaking about the HSV, VZV, and CMV. A lot of patients seen in our clinic might have HSV, and where you can get a medium to small size KPs, moderate AC inflammation. Posterior sign AK may develop during the course of the disease, might present with vitritis, and there is an iris atrophy component which can be present, and corneal hypoesthesia can be the important sign. For the viral varicella zoster, which is a very straightforward diagnosis, particularly in the context of herpes zoster ophthalmicus, you will see those clinical features of VZV present on the face and on the eyes, and then this patient present with the uveitis. So not so difficult when it comes to the diagnosis of varicella zoster related uveitis. Speaking in terms of CMV, which we see quite a lot in this part of the world, these are the younger patients in their third or fourth or fifth decade, present with high IOP with mild to moderate inflammation, but patients sometimes can be the little bit elderly gentlemen who can present to the clinic. They present with very mild ocular symptoms with low-grade inflammation and a round pupil. Some of these findings which have been picked up from publications from Professor Chi-Soon Paik in patients which can be seen, sorry for that thing, which can be seen in patients with CMV. So here in this picture, you can see the distribution of the keratic precipitates, which can be the small stellate kind of keratic precipitate, looks like a satellite KPs. And also you can get an immune ring, and very nicely demonstrated by Professor Chi-Soon Paik in her publication. Now, when you are confronted with a suspect case of a hypertensive uveitis, what do we need to do? What are the things which can be considered? ACTEP, yes, it can be considered, particularly to look for PCR for varicella zoster virus or herpes simplex or CMV. There are different groups reporting different positivity rate, but I will definitely suggest one should consider doing an ACTEP. What are the fallacies of ACTEP? A negative PCR might not rule out a viral etiology. In some cases, a positive result may only be obtained after the repeated taps, and PCR might also give a false positive. So one need to consider that. Particularly coming to the management of hypertensive uveitis, there are three main principles of treatment in hypertensive uveitis: is control of intraocular pressure, control the underlying intraocular inflammation, and treat the underlying cause if you are able to identify. Now, different IOP agents can be used, and there have been a whole lot of debate about prostaglandin analogs in patients with uveitis, so I'm not going to go into the details of it. Controlling inflammation is of paramount importance, and not many people pay attention to it. They think it's a mild inflammation, but you have to give these patients some form of topical steroid if you really want your IOP to be controlled. Only if it is controlled, the trabeculitis which is associated in these patients will be controlled, and then only your IOP can be controlled if you are giving the patients topical steroids. So what are the different forms of topical steroids? Again, a topic by itself. When do this patient need surgery? The surgery may be needed in the patients who are not controlled and they have a intractable glaucoma. My colleagues have been studying eye stent and all in the use in these patients. We haven't yet published our findings, but we're looking into this, whether there is any beneficial role of mini invasive surgery in these patients. Now, in context of HSV, VZV, and CMV, there are specific antiviral therapy which one need to consider, give it in patient to patient. And this is a simple algorithm. Just in case if you people fancy taking a screenshot, you can take it. Again, picked up by one of the publications from Professor Chi-Soon Paik, and you can definitely use it in your clinic if you ever confront with the patients of a hypertensive uveitis. Thank you very much for your patient listening. I will look forward for your questions. Thank you.